First of all, I'd also like to address a thanks to Nutricia to invite me and to be part of this very interesting and nice evening. I will talk to you under this heading, Sarkopenia, secondary to disease-related malnutrition. There are a number of overlapping catabolic conditions that affect function and survival, and tonight we will discuss the interaction between disease-related malnutrition and sarcopenia, which perhaps could call muscle failure or could be called muscle failure. It's a concept that seems to gain interest, this concept of muscle failure. The trajectory from robustness and health into disability and geriatric care or elderly care is a kind of two-track path, either through the aging process or alone, but usually combined with a disease. And of course, what we talk about tonight is very much the combination of aging and disease. And aging per se is related then to a loss of muscle mass, what we call primary sarcopenia, which paves the way for frailty. And disease, as we have discussed a lot already, is driving cachexia, and together with cachexia you have the secondary sarcopenia. And I think it's very important for us to realize the importance to recognize these, because these are processes that are responsive to intervention, and we have to be careful to do it in time and with the right mode. So, sarcopenia is still, I would say, a novel concept. I still meet a lot of colleagues that never heard about the concept of sarcopenia. Of course, you are here. I think that you're very interested in the field, but it's of course an old problem. It's as old as mankind, of course, but it's perhaps only in the last couple of decades that we have realized its importance, and it was the American geriatrician Irving Rosenberg who coined the concept like 30 years ago, and he thought that by giving this condition a Greek term, it perhaps could increase credibility of the condition. And that is what we usually do in the field of medicine, that we give the conditions that we work with a Greek terminology. And he was intrigued that we were, as people working with health in the health profession, that we were not realizing the importance, because muscle loss steals the freedom of the old. And that also indicates the very strong focus on old people when the concept was first discussed. But in the years after that, we have realized that sarcopenia is really nothing only exclusive for the older people. But still, we have to realize that the muscle mass loss is, in a lot of ways, I would say, a physiological process. We have indications that we lose up to 50% of our muscle mass, and the older we get, the faster it is. And of course, that is also then linked to muscle strength reduction. And this is an operational definition of sarcopenia as a syndrome characterized by progressive loss of muscle mass and strength, which Mars discussed, with the risk of adverse outcomes. And as we do with osteoporosis, we can divide sarcopenia into primary sarcopenia, where we really cannot see any other reasons than aging itself. And as with secondary osteoporosis, we have the concept of secondary sarcopenia, and there are causes identified like reduced physical activity, nutrition-related, but tonight we will discuss a little bit more about the disease-related sarcopenia. And of course then malignancy is one of those disease conditions. So how do we define then sarcopenia? And from the very beginning, it was very strong focus on muscle mass. But like about 10 years ago, there was an understanding that muscle mass is perhaps not the most important. It's perhaps more the function. So a number of groups kind of suggested very strongly that it should be a combination of reduced muscle mass and impaired muscle strength or power. And the discussions that are ongoing now, in order to update the diagnosis, is really to kind of make it the other way around, to focus more on muscle strength and a little bit less on muscle mass. But it's interesting, it's still of course important with muscle mass, and as Marit showed us, it's perhaps not the volume or the mass of the muscle that is most important. It's perhaps what is sometimes called the muscle quality. But what it was, the muscle quality in her studies were that you had fat infiltration in the muscle. So perhaps that is one of the reasons, or one of the things that we should try to measure in the future. We are not there yet. Actually, I think I skipped my next slide, because that was exactly the same as Marit gave us. Because when we discuss how do we measure muscle strength and power, there has been a lot of discussion about walking speed. Walking speed gives us a lot of prognostic information, but perhaps it's even more it's a more complex task to do, to walk, whereas grip strength is more straightforward strength. So perhaps we're moving into grip strength together with reduced muscle mass. So what are then the etiologies? Sorry, I forgot to do something that I always do, and that is actually because we're talking about sarcopenia, and then we need to have a short break. So every 20 minutes. So when this ring bells, we will have a very short break. These are the etiology that is in common between malnutrition and sarcopenia. And what is then the disease-related etiological moments? And we have discussed, and I will also discuss, the importance of inflammation related to the disease, inactivity, of course, then also insulin resistance. Insulin is an important growth hormone for muscle, and of course nutritional deficiencies related to the disease. And there are others, perhaps more age-related, also important mechanisms that then work or interact with the disease-related etiologies. Of course, we had this bed rest inactivity, and it's interesting to realize how we react differently by age on bed rest. These are studies showing that if you put healthy young males in bed for a month, they actually only lose about 0.5 kilogram of their appendicular muscle mass, which is arms and legs. Whereas only 10 days of bed rest in older people, they lose about 1 kilogram. Whereas if you have a catabolic disease and are, for example, a geriatric patient, it takes only 3 days of hospitalization to lose that big amount of muscle, which indicates that then hospitalization could in itself be a reason for sarcopenia, which we should realize also, and we should change probably our routines, ward routines. So there has been suggested this catabolic crisis model, especially for older people, where they have the general more age-related sarcopenic trajectory, but in fairly frequently then you may have pneumonia, you could have perhaps myocardial infarction, you will have hip fracture, and then you cannot really come back to your previous situation. So this is probably a very frequent way to become sarcopenic in older people. Physical activity is, and I think that is one of my major my major points of this presentation, is to really emphasize the importance of physical activity. This is a small study. They were recommended to, or they were advised then to reduce their activity from 6,000 to 1,500 steps per day for 2 weeks, not very long period of time. What happened was that during these 2 weeks they lost about 400 grams of leg muscle. Which is a lot. Do you count your steps? You have it in your iPhones and everything. Unfortunately, I'm not much better than that in general. 7,000 steps a day. But I have to say, I become a little bit frightened the day I become ill and will be put in bed, to lose this much muscle mass, which of course then also was related to glucose metabolism and also a higher inflammatory activity. So coming back to this disease-specific mechanisms behind sarcopenia, and of course disease, pneumonia, trauma, hip fracture, or, well, of course, that is, in this case, it is, of course, then a cancer disease, together with aging. They are all providing an inflammatory response, and the inflammatory response is, of course, good for you, for your homeostasis. You need the inflammation to activate your, well, a lot of healing mechanisms. But perhaps, at least in the long perspective, these are side effects. It doesn't matter too much, and perhaps they are good for you in the short perspective, that you lose your appetite, that you mobilize your proteins, and you mobilize your energy reserves. But of course, in the long run, that leads to cachexia and then to sarcopenia. This is another group of patients that usually suffers from cachexia and from sarcopenia, the chronic obstructive pulmonary disease patients. And it's interesting to see how thin patients, COPD patients, have a high inflammatory activity when compared to similar patients, but with normal weight, and also with compared to controls. And of course, when you have exacerbations, this inflammatory activity increases dramatically. And also, not very new for you is that body mass index, if the nutritional status is very strongly then related to survival. This is an old study, but I think still it's illustrative, because already at a BMI less than 24, if you compare these four groups, BMI more than 29, BMI 24 to 29, and BMI 20 to 24 and less than 20. You can all see that already in this group, after 4 years, you had only about 25% survival. And interestingly then, those with the highest body mass index had the best survival. And also interesting is that body mass index was the strongest single predictor of survival in these COPD patients. also after adjustment of these confounders. Congestive heart failure is similar. This is also old studies by Stefan Anker, who worked on this in Berlin and was very interested in cardiac cachesia. I think the interest, unfortunately, is not that big anymore, but it's of course it's important still. Also showing here that patients with congestive heart failure, they have an increased responsiveness to inflammatory stimuli. And interestingly, when doing retrospective or retroactive analysis in one of the early big ACE inhibitor studies, they could show that the strongest predictor of mortality within 35 months was a weight loss more than 6%. That was stronger than the ejection fraction and also the New York Heart Association classification of the severity of the congestive heart failure. So this is probably the most important mechanisms by which inflammation degrades or catabolizes your muscles is by, if you have an inflammatory activity, what happens intracellularly, for example, if this is a model of a muscle cell, the intracellular proteins combine with the ubiquitin, and this complex is drawn into this cylindric structure of proteases in order to degrade the protein into amino acids. And this is really happening because the metabolism of your body needs to be provided with alanine and glutamine for a number of metabolic reasons. So there is a reason for this muscle degradation. But of course, in the long run, it also results, if this is a protracted process, into sarcopenia. So what is then the role of muscle? At least from my perspective as a geriatrician, mobility and strength is, of course, the most what we think is most important with the muscle. But we have to realize that the muscle have a number of other functions as well. It's the only pool of amino acids that we have to use when we need when the requirements are increased for proteins. So we don't have, like for energy, we go with a depot of subcutaneous fat. So when there is an increased requirement, we use our muscle mass. Of course, glucose regulation extremely important. Liver and muscle are the major target organs for insulin activities. Energy metabolism, muscle cell uses about 5 times more energy than a fat cell, which of course you can then calculate what effect that has on your resting energy expenditure if you have the same body mass index but you have more fat tissue or if you have more muscle tissue. We today look upon the fat tissue as an endocrine organ, and muscle is an endocrine organ as much as the fat. And there's a very strong clinical relevance of sarcopenia. These are just a number of studies showing that quality of life is decreased. You have insulin resistance. You have it's coupled with osteoporosis, and we have this concept of osteosarcopenia just because they are so often kind of combined. And of course, osteoporosis and sarcopenia increases your risk of falls, and what happens? You have a hip fracture. Length of stays, readmissions, and mortality are increased. So it's really a very strong relevance of this condition. Okay. We saw this slide just in Alessandro's presentation. And this is a way how Espen have suggested to kind of divide malnutrition into groups. 3 major groups: disease-related malnutrition with inflammation, disease-related malnutrition without inflammation, for example, dysphagia after a stroke is not related then to the inflammation. And of course you have poverty or disasters and such things, floodings and such things. But what is perhaps in this sense most important, what we discussed today, is the disease-related malnutrition with inflammation. And we have discussed very much the role of cancer. I showed you some slides on COPD, congestive heart failure, of course infections, trauma, ICU. Most chronic disorders have a component of inflammation within it. And then it's interesting then to see, how do we really define malnutrition? And there's an ongoing discussion also on criteria to use. And interestingly, I was part of an initiative also coming from Espen that started like, well, 6-7 years ago, ended up in a publication coming then from Espen that suggested that step 1, risk screening, use any validated instrument and confirm the diagnosis either by body mass index less than 18.5, which is then the cutoff that the WHO say for underweight, but very seldom we find that low body mass index. So use instead then weight loss combined with either a reduced body mass index or a reduced fat-free mass index. So showing then the importance of the muscle when you define or diagnose malnutrition. Also highlighted in the diagnostic procedures that has been suggested from the cancer community and Ken-Fearon, for example. Interestingly, this was an initiative from Espen, and it really kind of ignited a very strong discussion within the community. So now, well, our colleagues in Aspen, in the South American community and in the Asian community, they were... Now I offer you 30 minutes of standing. 30 seconds. I mean 30 seconds. I count the seconds. You know, we talked about bed rest, and sit rest is probably as bad. So, and which is your biggest muscle? Which is your most important muscle? Your thigh muscles. So why don't we do like 5 of this? Have I counted right? That was 4, and now we're 5. Okay, thank you. Oops. So interestingly, our colleagues was not very happy with what Espen came out with. So there was a new initiative called the Global Initiative on Malnutrition, and this is work in progress. But I think we have come quite far, and it will probably be presented during the Espen Congress in Madrid in September. And what I actually want, I could go on for at least 15 minutes with this slide, but I would actually only want to stress that one of the phenotype criteria is reduced muscle mass. Also to stress the importance of the muscle mass when you assess your nutritional status. So then you could be diagnosed as malnourished if you have reduced muscle mass together with, example, an inflammatory state or cancer disease. Cancer disease together with reduced muscle mass would then be, and of course it also goes with cutoffs, but I will not go into that. So obviously we have a very strong connection between disease-related malnutrition, cachexia, and sarcopenia. So then I'd like to discuss whether we can do anything in order to prevent or treat this. And this is a list of a number of activities or treatment options. Nutrition in a lot of ways. Anabolic treatment. We talked a lot about inflammatory catabolism and how can we treat that? Immunomodulation and physical activity. I will try to show you some examples of what we can do. I would just like to start with, I think, a very strong study on oral supplementation, not really on sarcopenia, but the obvious importance of providing nutritional supplementation. It was this Nourish study that came 2016. It was a big multi-center study collecting 650 hospitalized patients. They had various diseases, and they were undernourished. And they were then randomized to have quite a big dose of energy, proteins, D vitamin, and a leucine metabolite compared with placebo. And after 90 days, mortality was reduced by half, which is a very strong outcome. So, and I would say that this really only confirmed the importance of providing nutrition to undernourished patients. But we're talking about sarcopenia today. So the question then is perhaps rather, how do we generate protein synthesis? Because although still we have not been very successful to show that muscle mass in itself is that important. But I think, and as it is discussed right now, is perhaps that we are not able to measure muscle mass the right way we should do it. As Mari told us, it was not muscle mass, but fat infiltration in the muscle mass was very important. So obviously, protein synthesis is important. And to activate that, we need to start transcription of and gene translation to produce the actin and myosin proteins. And to do that, we have to activate this mTOR-C1 complex. And we can do that by providing amino acids, by providing training, mechanical stimulation, and by anabolic hormones. So, resistance training. We talk about physical activity. Physical activity is extremely important for you, but perhaps when we talk, we mainly think about kind of walking, perhaps jogging, biking, swimming, which is good for your cardiorespiratory fitness, but it's not that good, it's not good enough for your muscle strength. So then, therefore, you need to do also resistance training, combine, and you don't have to do it always, but you can do like we did now, every day. When you get up of bed or something, just sit and stand for like 5 or 10 times. It provides something in the long run. There are numbers of studies showing that it's very effective also in old age and also during disease. But these are randomized control. This is a systematic review, and there was a couple of Cochrane meta-analyses, and the latest update was actually 2009, and they all show, and these are in older patients or older people, that you can have remarkable effects on strength, increased strength, and the latest one, large effects on muscle strength. So resistance training should definitely be the basis for any treatment or prevention. And also when it comes to whether should we provide nutrition or not, I think today it's a strong consensus that we definitely have to provide nutrition to the undernourished patient. So perhaps we are now focusing more on whether proteins for itself, or are there some essential amino acids? We talked about omega-3 fatty acids, vitamin D. And I will just show you some of the evidence. And there are not that much money in the field, so it's very difficult to really perform the big pharma studies, where when colleagues say that you don't have the studies that are good enough, of course that is because we don't have the money to do that kind of big studies, and because there is not that much money. Because of course for hypertension, a pharma company could easily pay to recruit 4,000 patients to show that they can reduce blood pressure with 2 millimeters of mercury, and that's very good for them, of course, and they have the money back easily. We cannot do the same, unfortunately. But we need to use the evidence that we have, and for protein intake, I will just show you some two observations from this health aging body composition study from Northeast USA, where they collected, they followed 2,000 older people over 3 years and related the change in lean mass with the intake of proteins, showing then that if you belong to those that had the fifth, that had the lowest protein intake corresponding to 0.8 gram per kilogram body weight, you lost about 1 kilogram in 3 years, compared to if you were among the quintile or the 20% that had the highest protein intake corresponding to 1.2 gram per kilogram body weight. They also lost, but they only lost half a kilogram. So high protein intake in an observational study like this indicates that you can preserve your muscle mass. Interestingly, the same author came back with a study just recently from the same cohort, now focusing more on mobility limitation. 2,000 old patients, 6-year follow-up now, relating tertiles of protein intake to the risk of becoming mobility limited, as having a limited walking capacity or limited stair climbing capacity. And the results showed then that if you compared, for example, those that had the lowest intake with those that had the highest intake, your risk was about double to have a mobility limitation. And you also had a significantly increased risk if you compared the tertile 2 with tertile 3. And we have come back to less than 0.7 and more than 1 gram per kilogram body weight. So this is also a strong observational study, 6-year observation. You could never perform a randomized control study over 6 years. So that is impossible. Okay, what do we know about when it comes to intervention studies? Let me show this on a small study, randomized control study on provision of essential amino acids after knee arthroplasty. Interestingly, to do knee arthroplasty, then you probably have a knee arthrosis, and arthrosis is one of the major reasons of sarcopenia. So these patients were probably sarcopenic. And so they did MRI for lean mass and also muscle performance tests, showing then that you could kind of preserve your lean mass by providing essential amino acids. You lost, but you did not lose that much. Your strength was actually increased by essential amino acids. And the timed up and go test, when you rise, walk 5-10 meters and go back and sit down again, you also you were able actually to improve your capacity by essential amino acids. But obviously the conclusion was then that essential amino acids protect lean mass and accelerate functional mobility after knee arthroplasty. This was a study that I was involved in myself, and we did it together with support from Nutricia, and that was a big multi-center study we were able to collect close to 400 older people. They were community dwelling. They were sarcopenic. And I think, come back to that they were sarcopenic was probably one of the keys of the relative success of this study. For 3 months, they were provided with a high dose of proteins every day, quite a big dose of leucine, quite a high dose of vitamin D, and compared then with placebo. Interestingly, and that is also when it comes to how we interpret outcomes of randomized controlled trials. Before the study was performed, we decided that we wanted to have short physical performance battery and hand grip strength. This is a combination of walking speed, of chair rise, stand, and balance. These were the primary outcomes. Interestingly, we could not see an effect on the primary outcomes, but on the secondary outcomes, we could see that the muscle mass was improved by this intervention, and also the time to perform the 5 chair stand test was also improved. But then it comes out as a negative study because you were not able to confirm your primary outcomes that were pre-decided or predefined. But still, of course, this gives us a lot of information. A similar study, also in sarcopenic malnourished older adults, provided with protein, HMB, leucine metabolite, and vitamin D, also a big group of patients. They were both sarcopenic and malnourished, lasted for half a year. Interestingly, here they actually tested 2 high protein formulas. And in both groups, leg and grip strength were improved. And they could, in some sub-study analysis, see that the test formula that contained also this leucine metabolite HMB had perhaps a little bit stronger effect. But what I think we can learn from this is that you have to, for all these 3 studies, you have sarcopenic patients. You have to start with sarcopenic patients, otherwise you will probably not be successful. And of course, it's interesting then to understand whether we could have an added effect by combining proteins and exercise. And this was another study that we very recently finalized. 150 subjects, all were provided with physical activity, but they were randomized then to a daily high protein, high leucine. And of course, the hypothesis was that the provision of extra proteins would increase the effects. But unfortunately, we could not see that. There was an improvement in both groups. Physical activity was significantly effective, which was expected, but there was really no effect on leg strength. But also coming back to the results of Moritz studies was that the protein supplementation. Now it's actually time for 30 seconds to stand up again. I just want to. It was an interesting. I think the outcome was still interesting. One thing was that we could see that the protein supplementation really reduced intramuscular fat, and perhaps in the long run that could be important. But I think as I told you, I think that you need to be sarcopenic. These patients or these community-dwelling older people, they were not sarcopenic. We selected them from mobility limitation, which perhaps was related to that they were kind of overweight. Because a similar study, when whey protein, essential amino acids, and leucine and vitamin D were randomly allocated then to exercising sarcopenic old adults, showed that the provision of proteins, of this mixture, increased fat-free mass, improved ADL score, IGF-1 improved, and hand grip strength improved. So perhaps it's perhaps not the intervention, it's perhaps a selection of the study group that are most important. Because if we compare, in this kind of successful study, they were leaner, they were sarcopenic, and they had a less hand grip strength. So I think that learn us who we should address. And then coming back to the current recommendations on protein intake, I'm sure that many of you work and are challenged by the recommendation coming from the latest Nordic Nutrition Recommendation Group from 2012. Actually, they came 2014, and these are actually the only official guidelines that say that for old adults you should provide up to 1.4 gram per kilogram body weight. So we will see whether other will follow, but I think that we have enough data to justify this recommendation. And we have a couple of expert statements that are not, I wouldn't say that they are not that elaborate as the Nordic nutrition recommendations, because they are much more work behind the official recommendations. But the European Union Geriatric Medicine Society came out with this ProTage paper recommending 1.0, 1.2, and for the acute and chronic disease or the cancer patients up to 1.5 gram, and that was exactly what Alessandro also said. And the same came from an ESPEN expert group a year later. Interesting, I think it's very interesting what we have in pipeline, and one of what we have in pipeline, of course, is fat quality. Vitamin D, I would say a couple of words on vitamin D. But fat quality, and that is interesting. We don't really know exactly how, but it's obvious that omega-3 fatty acids have a capacity to increase protein synthesis in muscle cells. This is a study in old adults, healthy, 6 months randomized controlled trial, and as I remember, it was a mixture of DHA and EPA. I don't exactly know the combination, the relative combination, and linoleic acid was a placebo. And the treatment effect, this is the treatment effect, was improved thigh muscle volume, improved hand grip strength, and improved one repetition, maximum repetition strength. That was also improved after 6 months of treatment. Well, so some of you remember providing omega-3 fatty acids to pancreatic cancer patients like 10, 15 years ago that were very promising. And then there was a big study also by Ken Fearon on big randomized controlled trial providing omega-3 fatty acids to patients with, I think, gastrointestinal cancers in general. Interestingly, and that came out negative and kind of killed the field for 5-10 years. But interestingly, when they did subgroup analysis, they could see that what happened was that everybody knew that they were either provided placebo or omega-3 fatty acids. So everybody actually went to the pharmacy and bought themselves omega-3 fatty acids because they would not risk to be in the placebo group. And because that was easy to see when they did the blood testing afterwards, because everybody increased their omega-3 fatty acids. And what they could see was that those that increased their omega-3 fatty acid most, they had the best effect on muscle mass and muscle strength. But that also came out as a negative study. Okay, a few words on vitamin D, because of course we know that there are a number of vitamin D receptors in the muscles. So why are they there? Of course, it should be good to provide vitamin D. But I would say that the evidence is still not that strong. This is a very small study also showing that by providing very high doses of vitamin D for 4 months, you can increase your fiber area. But of course, this was a too small study to see any effect on function. And this is, and interestingly, I cannot find many studies in this area yet. 17 randomized controlled trials on quadricep strength, and perhaps the most positive that came out from it was that, especially in those that had very low vitamin D blood concentrations, and when they had a deficiency, and if you provided vitamin D supplementation to restore their status, you could see an improved leg strength. Just a few words on pharmacology. Of course, this is a huge area, and the pharma industry would be very happy to have a drug with this indication, because elderly people, older people with sarcopenia is a very big target group. These are probably those with the highest interest for the moment, I would say. And myostatin antibodies. You know myostatin, you know the Belgian blue cows. They have these very big animals, they have very big muscles, and they have a mutation in their myostatin gene. So by blocking myostatin, you may have an increased synthesis of muscle proteins. So this is a study. I think it's Novartis that works with this compound for the moment, and they are quite advanced in their studies. This is a study on 40 community-dwelling subjects, older. They have slow gait speed and reduced muscle mass. Of course, then they are sarcopenic. Giving this antibody for 24 weeks, and you can see that you have positive effects on leg muscle volume, grip strength, walking speed, and 6-meter walking distance. So obviously it could be an effect from this potential drug. I think perhaps that it could be some ethical issues to provide healthy older people with the drug just in order to kind of spare their muscles. I think that we all agree that this is very much of a lifestyle problem, especially for healthy older people. So perhaps food and training should be the #1 treatments. We haven't talked about this anamorelin studies, providing ghrelin agonists to patients with non-small cell lung cancer, which is interesting studies, showing then that they could show in a series of studies in 500 patients with anorexia cachexia, provided this ghrelin agonist. Ghrelin is a kind of hormone peptide coming from your stomach, and which increases your appetite, but also has other quite pluripotent effects on anabolism. And by providing this, they could show that lean body mass in those patients were improved, no effect on hand grip strength, but the kind of quality of life or symptoms were improved. So they felt better. And it's also interesting that the FDA and many regulatory FDA and such organs, they tend to increase the importance of what is called the patient-related outcome measures. We have been very focused on objective measures previously, but now it's coming more and more the PROMs, or the patient-related outcome measures, and meaning then that symptoms and quality of life will be very important. So I don't know whether this, we actually in Sweden, it's an indication. We could provide this as an indication. And that's the reason for that is that the Läkemedelsverket or the drug administration in Sweden wants to kind of promote studies using the drug. Okay, I think I stop there, and my take-home messages when it comes to food, nutrients, and exercise for treatment and prevention of malnutrition and sarcopenia is that resistance training is always working. You always have to see whether you have a deficiency or not. And I can say that in the Western countries, we have a deficiency of resistance training. So you can really fill in a gap there. It always works. When it comes to nutrition, I think it works mainly when there is a deficit. It's difficult to provide or to start protein synthesis if you have already a protein intake that is enough. And for all of us, we eat more proteins than we actually need. So for us, it would not be helpful. But perhaps for me in 10, 20 years, it could be good. And for you in 40 years or something. But so I think it will work. And of course, we should, in that sense, we should target higher doses, There was very recently, I just wanted to comment that, a study, a 6-month randomized controlled trial a US study where they compared 1.3 grams and 0.8 grams per day for 6 months. The thing was that the participants were like 70, so they were quite old, but they were healthy and they were obese. So the general average weight was like 90 kilograms. So if you provide 0.8 gram per kilogram body weight protein, that I kind of calculated that, and that is about 400 grams of beef every day. So probably we need to adjust the recommendations to obesity in some ways. And that study came out negative, so the conclusion was that it's no use to provide older people with higher doses of proteins. So probably we need a little bit more research on omega-3 fatty acids, vitamin D supplementation. We should definitely avoid deficiencies. And when it comes to pharmacological treatment, I think we're not yet there. So, but of course, combinations of this will work perfectly well, I'm sure. So food and resistance training are keys to successful rehab, survival, and aging. So, thank you for your attention.